Thank you for your interest in our poster. Our submission pertains to the use of D-dimer and a tiered wall store for PE diagnosis. Pulmonary embolism, PE, remains a deadly cause of shortness of breath with a mortality rate up to 30% if untreated. The testing of D-dimer is highly sensitive for PE, albeit not specific. CT angiography of the chest remains the gold standard for diagnosis. A recent large clinical trial used a combination of D-dimer and Wells criteria for PE risk stratification in the outpatient setting, which showed that patients with a low pretest probability Wells score of 0 to 4 and a D-dimer level less than 1,000 nanograms per ml could rule out PE. For patients with a moderate pretest probability Wells score of 4.5 to 6, PE was unlikely when the D-dimer value was less than 500 nanograms per ml. The aim of this study is to assess this tiered Wells score method in the ER and inpatient setting to reduce reliance on CTA of the chest to rule out PE, thereby reducing both radiation exposure to patients and healthcare costs. For our methods, we compiled a list of all chest CTA orders in the ER and inpatient setting to rule out PE at our hospital from November 2018 to November 2019. Patients' charts were analyzed with retroactive calculation of Wells score when appropriate. Pre-test D-dimer values were obtained whenever available. It was presumed that PE was the most likely diagnosis when CTA of the chest was ordered. Thus, 3 points were automatically added to the Wells score for all patients. Per Wells criteria, an additional 3 points were awarded for physical evidence of deep vein thrombosis, DVT, such as peripheral swelling or lower extremity venous duplex ultrasound. 1.5 points were added if the heart rate was charted as greater than 100 beats per minute before the CTA chest was ordered. Other criteria included 3 days of immobilization or surgery in the month prior, which garnered 1.5 points, prior PE or DVT, which garnered 1.5 points, and hemoptysis, which garnered 1 point. Any mention of malignancy with treatment within the last 6 months or palliative care consults in the admission note garnered 1 point. Our results showed that 451 out of 718 charts, 63% of charts lacked D-dimer testing altogether. Of the 267 charts with an available D-dimer, 124 charts had a D-dimer level less than 1,000 nanograms per ml. We found that when coupled with the Wells score, appropriate risk stratification would have spared 77 patients from undergoing unnecessary CTA imaging. One outlier patient had the incidental finding of a small PE on chest CTA, despite our criteria suggesting that she should have foregone CTA testing. In conclusion, our results validate that a combined Wells score and D-dimer approach have overwhelming potential in the inpatient setting to reduce the overuse of CTA for PE rule-out. While a D-dimer level greater than 1,000 nanograms per ml should rightfully earn the patient a CTA of the chest with high suspicion for PE, patients with a D-dimer value less than 1,000 nanograms per ml often undergo unnecessary chest CTAs. Our data suggests that patients with D-dimer less than 1,000 nanograms per ml should have a Wells score calculated to determine the necessity of the CTA of the chest. At our facility alone, over only 12 months, 28% of patients would have ruled out for PE based on the dual Wells score and D-dimer model, avoiding radiation and iodine contrast exposure. Despite the single outlier patient noted, we conclude that using the Wells score and D-dimer combination is an effective method for PE risk stratification in the inpatient setting.